Good afternoon, everyone, and welcome to today's webinar. I see a lot of familiar names from last week's kickoff. Thank you so much for joining us. But we know that not everybody was able to come. So if you didn't come to kickoff and you would like to know more about the Obstetric Hemorrhage Initiative, our website already has one tab for obstetric hemorrhage OHI 2.0. And you have the toolkit, you have the presentations from kickoff, and some of the resources that will be available for the initiative. So we will drop the link to the website in a second. So if you want to know more about the initiative, please go there. Today, we are going to have a brief recap of the importance of OHI, but then the main theme of today will be data and how we're going to collect it and the tools that we are going to utilize to make sure that we're collecting the information we need to report on the initiative. So just a couple of housekeeping items. Please make sure that you mute yourself to reduce the background noise. If you have a question, please enter it in the chat or raise your hand and we will get to you. We will have two sections for questions, but you can drop your question anytime in the chat. But if you want to wait until the question sections, there will be two opportunities, and we will love if you want to come out of mute and just raise your question. The webinar is being recorded and will be available in our website, in our YouTube channel as well next week. So that is coming as well. So for OHI 2.0, you see that we have units that have joined us from throughout the state. We have 50 Florida maternity hospitals in OHI 2.0 that represents 48% of births in the state. So we have the potential to have a huge impact in the maternity care of women that have obstetric hemorrhage in the state. We are very, very excited and very thankful that you have participated, that you have decided to join the initiative. And there's many reasons why we are working on OHI 2.0. One of them is that we have updates in key clinical guidelines. We did OHI 1.0 back in 2014. A lot of units worked on it and we did some good improvement. But since then, many things have changed in clinical practice. We know that now we have updated guidelines on identifying and treating anemia. We have TXA. We have the devices for balloons and vacuum intrauterine devices. And so there's a lot of things that have changed. And so we saw that it was important to bring those to the units, make sure that those are standardized and people are using them and working on them. But beyond that, we also saw some changes that are interesting and need to be addressed on the population data, right? So from 2018 to 2022, we have seen that obstetric hemorrhage rates in Florida have risen by 23%. We still have disparities in the outcome. And on the Maternal Mortality Review Committee, which is the committee that reviews every maternal death in the state and determines if there was any relationship with the pregnancy, we have seen that is still a leading cause of pregnancy-related death in Florida. But beyond that, 85% of those cases were deemed preventable by the committee. So there's a lot of things that can be changed to prevent those deaths in the state. And when we look at the underlying causes of pregnancy-related death from the Maternal Mortality Review Committee, we realize that the biggest cause among the obstetric hemorrhage deaths is due to uterine atony, followed by placenta accreta, uterine rupture, and placental abruption. So you see all the causes in black. When looking at the cases more closely, we realized that they were deemed 100% preventable. There was something that could have been done to prevent those deaths, and for every single one of those deaths, right? And some of the reasons were due to delay in recognition and treatment. So you're going to see that for OHI 2.0, we are focusing heavily on early recognition and treatment because of that reason. For placenta accreta, we know that is a more difficult condition to treat, and so 40% of them were deemed preventable. But there was an interesting information there as well. 100% of those cases actually had a previous cesarean section. So even though there was not preventability opportunities during the current pregnancy, we have to think about those cesarean sections and how they have been rising in the state as well. Looking at the MMRC data again, we wanted to explore a little more, and we found a very usual scenario among those mothers that died because of an obstetric hemorrhage. The very first thing is that most of them had a risk assessment at admission to L&D, but it was the only one that was documented, no other risk assessments, right? And sometimes those risk assessments were not accurate. Sometimes they had risk factors and they were categorized as low risk. So we know that assessing that risk assessment is important to do it accurately, but we also know that it needs to happen more times. Not only at admission, we need to do it pre-birth, we need to do it at admission to postpartum, and every time that the condition of the patient changes, because that helps us identify those early clinical changes that may alert us of problems down the line. So very, very important to have in mind that those risk assessments need to be done accurately and multiple times throughout the admission. The other issue that we saw for the MMRC cases is that they didn't have cumulative QBL. Most of them had only EBL or like very raw approximates. So we know that QBL, again, is super important to alert us of problems, of issues, to stage the OB hemorrhage and get access to additional resources timely so they can, we can react quickly and promptly to the problem when it happens. And so all of those reflect a delay in recognition and treatment. And that is one of the reasons why for OHI 2.0, our big aim is centered around those two very important things. So by December 2026, 20 months from now, our OHI hospitals will increase by 20% the percent of patients receiving one, hemorrhage risk assessments completed on admission to L&D, pre-birth, and on admission to postpartum. And secondly, we're going to increase the amount of patients that have QBL, cumulative, documented from birth to recovery, right? So those are the two things that are going to be our main objectives for the initiative. And this is not meant for you to read. This can be very overwhelming, but this is our key driver diagram. And so the aims that I just shared with you are on the left. And then we have the key drivers that are those big buckets of changes, ideas. So you can see that their readiness, recognition, and response. And then on the right, you have the secondary key drivers. So for data collection, we know that data collection is important in quality improvement because what gets measured gets managed. And so we have a measure for every single one of these key drivers listed on the right. Because the idea is that as you implement them, we measure them and track them to see if they are getting us to our aim. So today we're going to share with you the tools that we have created to collect the information that is going to be reflected on those secondary key drivers and the schedule that you need to report those data to us. So we have two important levels for data collection. The first one is the patient level data, and that is going to be your abstracted patient data. We're going to have a number of records abstracted every month, and we're going to ask you specific questions about what we are collecting for the initiative. Patient level data needs to be completed or submitted to FPQC monthly. And Shelby is going to give you all the details about when baseline is going to be submitted and when ongoing data is going to be submitted in just a moment. But right now, the big idea is that you get that we're going to have patient level data on one side and then hospital level data on the other side. So hospital level data is the aggregate information. You're going to tell us if you have fully implemented the structural measures that are the policies, the processes, the guidelines that are going to support OHI 2.0, as along with the staff education and training and the aggregate SMM or severe obstetric complication numbers. So you see that patient level data, the abstracted data that you're going to submit to us is going to be done monthly, and then the hospital updates and the SMM and the staff education numbers are going to be quarterly. And again, we're going to go in detail now. So for that, Shelby is going to walk us through the monthly abstracted patient level data. Shelby.
Thank you so much, Estefania. Let me pull up my slides here. All right. All right, so now we're going to go into the monthly abstracted patient data. So for our patient sample, the inclusion criteria is going to include patients who deliver at your hospital and experience greater than or equal to 1,000 milliliters of blood loss, aka stage 2 obstetric hemorrhage. The case selection each month to abstract our data, we're going to have up to 10 stage 2 hemorrhage cases and then up to 5 stage 3 or 4 hemorrhage cases. Now, just up to 10 and up to 5 for a total of 15. But it's hospital specific. So if your hospital doesn't have 10 or 5 of these stage 2 or stage 3 or 4, that's okay. It's just as many as your hospital has every month. And the max we want, if you have a lot, would be 10 and 5. Again, a total of 15 of these cases. And we're going to use the patient level form for this. So next, we're going to go over the steps to collect your monthly abstracted patient data. Where do we look? How do we collect the data? And where do we submit it? So step number one is we want to make sure that we have multiple sources of data. So we are going to look at documented blood loss in the EHR, OB hemorrhage staging if your hospital has it, ICD-10 codes. There is a list from AIM that we will be sending you whenever your DUA is completed and you get all those first steps for your data collection. We'll send you those ICD-10 codes, as well as the use of TXA and the use of intrauterine vacuum assist device or intrauterine balloon tamponade system. And again, we have multiple types of data listed here because you shouldn't just rely on ICD-10 codes alone. Make sure that you're using multiple sources of data to ensure that your case selection is accurate and is complete. Nobody slipped through and nobody's getting misclassified. All right, now that we've wrangled all our data together, we're looking at all our cases that we could possibly abstract for. We're going to start selecting cases. So the first 10 are going to have that cumulative blood loss of 1,000 milliliters or greater. So a stage 2 obstetric hemorrhage. So we're going to look for 10 of those stage 2s. Next, we're going to look for the first 5 patients who live at your hospital who experience a stage 3 or 4 obstetric hemorrhage. And again, this is up to 10 and up to 5. It depends on how many your hospital is getting, and you can submit less than this. So for our stages, we're classifying them based off the A1 postpartum hemorrhage stages algorithm. So those of y'all that came to the kickoff, you saw this algorithm. We were handed out some laminated versions of this. So you're already familiar with these stages if you came to the kickoff and you've presented them to your QI team. All right, so now that you've got all your data, now it's time to submit it to us. So the cool thing about this is you've already seen this data collection form at the kickoff. Now we're going to kind of break down each quadrant and go into some more detail. And your baseline data is going to cover January through March. So we're doing something a little bit different than we've done in other initiatives. We're going to go back in time, look at abstract patients in January, February, and March. And those samples will be due to us by July 15th. So you have some time, but if you want to get ahead of the game, it is live. So as soon as your DUA is processed,
Wow.
and then you've got that submitted to us, you can go ahead and abstract this patient level data like starting next week. So you have from now until July to abstract for January, February, and March. All right. So at the very top, we've got our demographic section. An important thing to note here is we have study ID at the top. And so your very first patient is going to be 001. And these numbers will continue to increase and consecutively go all the way up throughout the initiative. So if I start at 1 this month and I end at 15, the next month I'll start at 16 and I'll end at 30. So we're going to keep going up. Remember the very last number you ended with because you're going to start with the next number the next month. Then we've got diagnosis related to OB hemorrhage here in the bottom right corner.
The
There
study
it,
ID, you said it's gonna be.
it didn't sound like a question.
Yeah, Elizabeth, you
Um,
could ask a question.
Oh, sorry. Oh, okay. Okay. She said that the study ID is gonna be we have to put like 001 for the first patient until 015 for the first month. And then we go the next month, it's gonna be 016. That is, okay, okay.
yes, you got that correct, Elizabeth. Thank you. It was a great question because sometimes it's confusing what number, but we're just going to go up, start with one, and we're going to continue to go up throughout the whole 18 months that we're doing this. And in the bottom right here, we have diagnosis related to OB hemorrhage. We do have a other box here. And just to let you know, that does not include death. So this demographic section is going to help inform our case composition, and we can track population changes over time. And the ability to disaggregate these measures, it can help us to identify differences between population groups. So definitely a very important section. And then here you've got your OB hemorrhage stage 2, 3, and 4 listed. And again, this is based on the A1 staging criteria, that lovely laminated staging criteria you got. If you're not sure what I'm talking about, I'm sure we'll have it in the website soon. So you'll be able to see that. All right, next is our OB hemorrhage identification and management section. I just want to draw your attention here to the documented blood loss. It is in milliliters. Next, we have our, medicine and medicine section, as well as your devices and different blood products related to what kind of interventions were needed. So when we have devices here, what devices are we including? Well, you've got devices for intrauterine balloon tamponade listed here, and then devices for intrauterine contraction via vacuum. So the JADA system, and well, if you forget how we're classifying this information will also be on the data collection instructions. In the data collection form, we'll have some definitions at the bottom. All right, so next we're getting into the clinical debrief and case review section. So at the bottom here, we're asking about, did the physician and RN debrief the case? So what do we mean by this? What kind of debrief are we talking about? So this debrief that we're talking about directly is going to be a quick structured review after the event between the RN and the physician to summarize what happened, highlight the successes, and also highlight areas for opportunity or maybe barriers. And then how can we improve rapid improvement throughout this debrief for future patients? So we've got a standardized form for you guys if you don't already have one already in your unit. It is from A1 and it's going to be available in the toolkit. So next, if this was an SMM case, we want to know if an interdisciplinary case review was conducted. So by this, we're aligning it with a TJC, maternal safety standards, as well as AIM for this definition. So it's regularly scheduled reviews of severe maternal events by an interdisciplinary team to identify systems, issues, and opportunities for improvement. So here's an example of the team
Excuse
debrief
me.
form that we have.
I have a question. So
Yes.
SMM is like a risk, like an origami, kind of like a system.
Hi, Rosa. So severe maternal morbidity is a composite measure. It has 21 diagnosis codes that highlight those sentinel events or those very, near-death events. Right, the sentinel events, there you go. So we will send you a list of the diagnoses that are included, and we use the CDC definition. But now we know also that hospitals have access to the severe obstetric complications measure, so you can use that one too to identify those patients. Either one works. Thank you for your question.
Thank you, Rosa. All right, so here's a team debriefing form. We have an example of this also in the toolkit for you guys to utilize. Who was involved, what was discussed, and areas for improvement looking forward, as well as the staff involved. All right, so discharge management is the next section. In this section, it'll ask is, if the patient was debriefed. So different from the clinical debrief, what we just went over, this part is asking, how was the patient debriefed? And were they given a written summary of the event before discharge? So again, how are we defining the patient debrief? Because I know we can define it in different ways depending on our hospital. But what we're asking here is if it was a structured conversation between physician, nurse, and patient where they went over the OB hemorrhage event, including, any complications, the treatment that was followed, and any follow-up care that the patient can do or knows to expect. And then also patients receive a written summary with the details of the event. So if all these things were completed, then you can mark yes for this in discharge management. Again, we're looking for the whole team getting together and just making sure that the patient was kind of given a summary of, what happened to them and what they can expect going forward for follow-up care. All right, and the last part is the timing of schedules of scheduled follow-up appointments. So these follow-up appointments should be scheduled prior to discharge. So note how many days after discharge the appointments are scheduled. If not scheduled and the patient was instructed to schedule after discharge, then choose patient instructed and not scheduled. So again, we're making sure that this is scheduled either by you or someone else within the care team for the patient, and it's done before they leave. Sometimes I know this is difficult with staffing, so make sure that you choose the patient was instructed or not scheduled if you weren't able to get a confirmatory scheduled appointment before the patient leaves. Any questions about these two items? Brandy.
Yes, I do have a question. What is the recommended follow-up for postpartum hemorrhage? Is it still just within the 2 weeks or sooner?
For those, we are looking for the early postpartum visit, Brandy. Very good question. So we will be looking at those 2-week appointments that should be available to all patients after a delivery. Unless there's other complications, of course, which, if the patient also had hypertension, then you would be looking at the 3 days, but that would be because of the hypertension.
Okay,
But for
thank you.
obstetric hemorrhage that was resolved at the hospital and didn't cause significant, long-term or short-term complications, then you would be looking at the regular 2-week visit.
Okay, perfect.
Great question. Thank you. All right. So here's an example of a patient summary form. We'll also have this in the toolkit for you guys to utilize if you don't have one already on your unit. And then also, let me show you where this is. There was a section about a postpartum discharge assessment. A lot of you guys might recognize this from PAC if you're involved with that or just seen it before. So we do have an example of a postpartum discharge assessment here, and it will be available on our toolkit. And this is editable as well. So you guys can change any of these numbers based on your policy or protocol that you have, or even add things that you're continually looking for in your discharge assessment. All right, so now I'm going to pass it over to Alexa, and she is going to take us into this patient level form and show us what it looks like.
Yes, thank you, Shelby. Let me share my screen. Okay. So for those of you who have done an initiative with us, especially prompt, this will look somewhat familiar, though admittedly not as complicated. This is the patient level form. You will receive the link to this once your DUA is completed, and Estefania will send the links to submit data. So just a quick overview, this top section is the demographics area. You'll put your hospital name and your email address, the discharge month and discharge year. If for some reason smaller hospitals may not have any eligible patients to report, you'll choose this box and all of the questions will disappear. But you will only do that if you don't have any patients, eligible patients to report to us. Here's where you'll put the study ID that Shelby mentioned. Again, this is going to run concurrently through the entire initiative. Don't restart the numbers every month. It just makes it easier to keep track of which patient is who while remaining anonymous. You'll mark whether it's Saturday, Sunday, holiday discharge, the patient age, and then here's where you'll put all the demographics. Anything that's a square check mark is a multi-check. And anything that says other, a box will pop up and it will require you to answer that. It will require you to put an answer in here. It won't let you submit it without putting an answer in. So you'll do ethnicity, race, primary language, insurance type, delivery type, and the diagnosis. And again, this is a select all that apply. Here is a free type. Well, you'll put the gestational age at delivery for the patient, the hemoglobin at admission, which stage they experienced of hemorrhage, and the time frame when the OB hemorrhage started. The next section is the OB hemorrhage identification and management section. So you'll mark when the risk assessment was given. Again, it's a check all that apply. We're looking for all three of these to occur. The documented blood loss in milliliters, whether cumulative and quantitative blood loss technique was completed, whether the patient received active management of the third stage of labor, and the number of documented handoffs reported for the cumulative blood loss. The next section is where you'll report to us the medications and interventions completed. You would check all that apply. I have a couple of these marked because there are extra questions that will pop up if you mark them. So any of these medications that you choose will populate this table where you will tell us after the hemorrhage onset, select the order of medications given. So this is really important. So you wouldn't have the same answer for, you wouldn't have, you know, both of these medications listed as first. You would tell us which one was given first, which one was given second, and then if there was more than 2 medications, you would mark other. And then you will mark yes if any of these are contraindicated. As far as interventions go, if you mark TXA, we ask at what time from the onset of the hemorrhage it was done. And if you mark if you mark devices, excuse me, we'll ask which device was used. And if you mark surgical interventions, we'll ask which surgical intervention was used. But if you don't have those clicked, you won't see those questions. So I wanted to make sure that that was shown. And then similar to other patient level forms we've done, we'll have the adverse maternal outcome section here. Again, if you choose other, you'll have to free type in the answer. And adverse neonatal outcomes is the same. Choose all that apply. And if you choose other, you'll have to tell us the answer. And then we ask yes or no or not applicable. Did the physician and RN debrief this case? If it's an SMM case, was an interdisciplinary case review conducted? Yes, no, or not applicable. And then again, similar to other initiatives, we have a discharge management section. That's what Shelby just went over. So we're gonna pause here and see if anyone has any questions.
So we have a question in the chat. Do handouts in the postpartum discharge folder of the postpartum warning signs count?
I can answer that one. We give all patients the post-birth warning signs. So what we're looking for is when somebody has an actual postpartum hemorrhage, the additional education you are providing, along with that documentation that the physician explained what happened or the midwife. So there was that provider to patient education. They will go over more things related to that hemorrhage and things they should be watching for. So does that answer your question? So post-birth warning signs alone would not meet it.
Yes, thank you, Margie. That's an excellent explanation. So when you look at the measure in the data collection form, it's going to ask you if verbal and written materials were given, right? So the education component that Margie just shared would be the verbal aspect of the question, right? Both are needed. Just given the pamphlet or the flyer is not enough. It has to come with the verbal education.
There was also another, Margie, this may be a you question, in the chat from earlier. It says, for the medications, does the normal postpartum PIT count if it is infusing, or is this if we administer an additional dose?
So it's beyond the, oh, go ahead, Stephanie.
Yeah, no worries, Marge. I think we're going to say the same thing.
Yeah.
So in that data form, the header of that section says if to only check those medications given after the hemorrhage started. So once you have seen that there's excessive blood and you know that the patient has an obstetric hemorrhage, the medications that you are providing in response to that. So yes, we know that oxytocin, additional oxytocin would be the first step for many. So you would report that one, not the usual one. The usual one that you give to all the patients, then you don't need to report that one.
That's exactly what I was going to say.
And the header of the question in the data form
Yeah.
does specify it. So just that. And thank you, Margie, for responding that question about the pre-birth assessment. If anyone hasn't seen it, you know, I think it's important to have it to everybody. So do you want to expand on it?
Yeah, just, you know, with A1, when they came up with, you know, prior to birth, we don't have a crystal ball. We don't know when birth's going to be. So a lot of people do it once the second stage starts, once you start pushing with the patient. But ideally it's, you know, right before birth. So if she's pushing, you know, for a couple hours, you probably need to reassess.
Absolutely. There was another question about the data collection forms. The data collection forms, we will send them to you via email either tomorrow or early next week. You will have both the patient level, the hospital level collection forms, and the instructions. Because as you heard, we are asking you to collect retrospective baseline data. So that's going to be from January through March. So we really, really hope that you are able to start collecting that information early. Don't wait until the DUA is signed, because for many of you, it will take a while before we sign those DUAs. And so if you can get started on, you know, identifying those sources for collecting that information and getting those forms ready for submission, that would be extremely, extremely useful. And FYI, the data collection, the DUA, the data user agreement that we need to sign, was approved by Legal USF because it's a legal document that we have to get through a lot of places before it goes out to you. It was just approved. So Dr. Linda Dedman is the one that handles all that, and she will send that to you next week. So, you know, the MT data user agreement that you need to route at your facilities to get signed at your facilities and then return to us, that will come to you next week. So just FYI, try to help us execute it as soon as possible. If you have any roadblocks, contact us. Most of the time, it just takes talking to somebody in legal or research or anybody that is giving you trouble. Please, we are more than happy to jump in a call with them and help you figure out what the roadblock is. But those will come to you next week.
Stephanie, I had a question. I'm sorry.
Hi, Shamika. Of course.
How are you?
Rocking.
I know, right? Just to clarify, the baseline data that's due July 15th, that's January, February, March. Are you talking about the hospital baseline data that we usually submit, or patient level data? So 45 audits.
Yeah. So
Correct? Okay.
Alexa will give you more specifics on the hospital level data, but we're talking about both. So this time around, we're doing patient level data as well as hospital level data. And the reason is because when we were at kickoff, and even before that, we had talked about the risk assessment and the QBL being done at many, many facilities. So we really need a true baseline, because before we have used the first 3 months of the initiative once we get started and we just start to collect then. But we heard from many places that you guys are already doing some of that. So we wanted to capture a true baseline so we could truly see the impact of the initiative and what has changed. And so that means collecting data retrospectively from January through March. So it's going to be for both, for patient and for hospital level. For hospital level, again, Alex is going to give you more details, so I don't want to get too much on it, but yeah, that's the short answer. It's going to be for both.
Thanks for clarifying.
And we have there's one of the last slides on this PowerPoint, which will be on the website as well, has all the due dates and all of the information for what's due for baseline. There's one more question in the chat. Rosa, you may want to unmute and ask us because I'm not quite sure what you're asking. It says the last form reviewed, what is the difference? So if you're still there, we might need you.
Yeah, so it looked like it was basically the same from this one.
From the one that
The same information.
Yeah.
So what is that though? What is what you were just going over recently?
So what was on my screen was that form in REDCap, which is the survey that you'll use to submit your data to us. So that paper form is only for you. You wouldn't turn that into us. You'll take that information, submit it on REDCap.
Oh, got it. So, and we'll be provided the link or wherever we submit it?
Yep. When your hospital finishes your DUA, Estefania will send you the link.
Okay. Thank you. Sorry for clarifying.
No,
Thank
you're
you for
fine.
clarifying and sorry for the questions.
You're totally fine. Any other questions before we move on? Okay. Don't know why I muted myself. I'm still talking. Okay, so for the quarterly hospital level data, there's two sections. There's the aggregate patient level data, and then there are hospital policies and procedures, and we'll go over that now. For the quarterly aggregate patient level data, we're going to ask you the total number of patients who had completed postpartum hemorrhage risk assessments and cumulative QBL documented. And then we will be asking you about the total number of patients with SMM or severe obstetric complications and SMM and severe obstetric complications among those who experienced OB hemorrhage. So just total patients who had SMM or SOC codes, and then those that had those codes along with a hemorrhage. That will make more sense when you see the form. So here's what the form will look like on the paper version. It will look a little different on REDCap, and I'll show that to you. So aggregate patient level data, we're asking the total number of patients admitted for delivery at your unit. Then we're asking total number of patients admitted for delivery with a documented QBL, cumulative QBL in their chart. And then we want to know the number of patients admitted for delivery that had 3 risk assessments completed, 1 at admission to L&D, 1 pre-birth, and 1 at admission to postpartum units. And then the next sections are calculated using those ICD-10 codes, which you'll see in a second, and also will be sent to you when all the data instructions get sent out. But we're looking for the number of patients admitted for delivery with obstetric hemorrhage using ICD-10 codes. We're looking for the number of patients with SMM during their delivery admission, and you'll exclude the transfusion-only cases. Number of patients with SMM, excluding transfusion-only cases, who experienced an obstetric hemorrhage. So this first line is all your patients who, during their delivery admission, had SMM. And the second line is all of those patients who how many also experienced an obstetric hemorrhage. And then the next 2 lines are the same concept, but instead of SMM codes, you're using severe obstetric complication codes. So the number of patients with severe obstetric complications, excluding transfusion-only cases during their delivery admission. And then those same number of patients who also experience an obstetric hemorrhage. Oops, let me go back here real quick. So for the severe obstetric complications, I believe Shelby went over this, but those are required for CMS. They are optional for us. So SMM is not optional, but the severe obstetric complication codes are optional for us because we know that not all hospitals necessarily use those codes. And then up here, there's been a couple questions in the past with other initiatives. These first 3 lines are for all patients, not necessarily patients who experienced a hemorrhage. This first line is just total number of patients that were admitted for delivery for your unit or your hospital in that quarter. Here is a screenshot of the ICD-10 codes for obstetric hemorrhage from AIM. Again, this will be sent to you and in both this presentation as well as in the data instructions. Same one. And then for SMM, so Stephanie covered this earlier, but SMM is defined as an unexpected outcome during the delivery hospitalization that results in significant short and long-term consequences to a person's health. You have to set up a report in your EHR with IT using the SMM codes. This screenshot is a screenshot of AIM's website. I have the link down here for you. This is where you can get the SMM code lists if you can't find the email from us or you don't go to our website. But again, this will be on our website. This will be emailed to you. And then again, as I said, this information down here are codes that are required for CMS, but they're optional for us. And then again, another reminder that you will be submitting your baseline data that covers January through March by July 15th. If you're unsure about your SMM numbers for your hospital, you can review your PQI report to verify the number of cases you've identified is close to what you've submitted in your report. If you're not sure what PQI is, you don't know who your PQI person is at your hospital, you can email Shelby and I, we can get you in contact with them. This is a screenshot of what the policies and procedures section of the hospital level form looks like. You'll have your policies and procedures that we're asking you to implement on the left-hand side. And every quarter you'll report for each one, whether you've not started, you're in planning and development, you've started to implement, you've implemented, or you fully implemented. And this is just a closer screenshot so that we can show you that started to implement, we define as implementation began within the last 3 months. If you've implemented it, it means that you've been implementing it for more than 3 months, but it's not routine practice in your hospital or your unit yet. You're doing it less than 80% of the time. And then if you've fully implemented it, it means that you've been implementing that policy for more than 3 months and it's considered routine practice. You're doing it more than 80% of the time. So I am going to show you the hospital level form. Can everyone see this one okay?
Yeah.
Okay, I was gonna say, I'm gonna guess yes, because no one's yelling now. So this looks somewhat similar to the patient level, and it looks very similar to other hospital level forms we've done if you've been in other initiatives with us. So you'll put your hospital name. You can scroll, but also you can just start typing and pick your hospital. You'll pick your reporting quarter. Right now, we only have baseline showing because that's all that's due. But as the initiative kicks off with its active data phase, you'll see quarter 1 through 4 listed here. You'll choose your year, which right now your only option is 2025. And then if you forget, here are the definitions for what each of these answers means. You've got all of your policies and procedures here, and then you'll just go through and click and tell us where you're at with each one. And then as you keep scrolling, there is one that asks about drills. And if you click that you've started implementing that or have implemented or fully implemented it, you'll have to tell us how many drills you've done in the last quarter. And then here is the section with the aggregate patient level data. So here's the top 3 patients admitted for delivery, patients admitted for delivery with documented QBL, cumulative QBL, and the risk assessments. Here is the section for SMM. And here is the section for severe obstetric complications. And then here is the section where you'll tell us the staff education and training. So how many nurses and physicians and midwives have received training on obstetric hemorrhage policies, guidelines, or procedures, and how many of the same population has received training on respectful care and committed to respectful care practices. You'll put in your email and submit to us. So let me flip back to my PowerPoint. Shelby, do you want me to run for you or do you want to do it?
I got it. Thank you.
Great.
All right. So those questions in the chat, we'll get to them after this last section of our PowerPoint. So I'm going to wrap us up with just things to keep in mind, some good housekeeping tips as you go through your data collection. The first one is make sure you maintain a record of your cases. We have an example for you to use in the data collection instructions, but you're also open to use whatever Excel spreadsheet you would like to create. But make sure you keep the medical record number, the study ID number, and the survey return code, as well as the data lead name or whoever submitted that data. This will be extremely helpful because we continuously go through the data and review it and clean it up. So if we have a question about something, it will be easy for you to go back to that record. If we ask you about study ID 21, you already have the return code, so you can go back into REDCap and make edits accordingly. And again, this is just for you to keep for your own records. We do not need a record of your cases or anything like that, but it'll be extremely important for you to keep a record of everything that you're submitting and who is submitting it for future purposes. Next, I want to show you some examples of how your data is going to be shown to you in your monthly data reports that you'll get from the data team. So first, you've got, this is an example from our Mother Focused Care initiative. This is their referral dashboard. You'll have something very similar to this, kind of where we look at our 6 key measures, and we've got slicers on the side where we can disaggregate by that demographic information. And then we'll keep check monthly as well as quarterly through graphs that will look just like this one. Next, we'll have a bigger picture, more focus on our main aims and measures going forward. This is an example also from Mother Focused Care. But as you can see, we're looking at percent of patients with positive SDOH that were referred. So the black line is your hospital. It'll show you how your hospital is lining up with other hospitals, whether you're in the top 25% or the bottom 25% or somewhere along the middle, close to that pink median line. That's how you can interpret this one, as well as the quarterly progress on the bottom there. So those are 2 examples of what you can look forward to. And how does this data kind of fit into the overall picture of your monthly QI cycle? Well, your QI reports are going to always have measures that relate to the aim. We'll look at run charts as we collect more and more data points to see what these points indicate, whether an increase or decrease or areas for improvement. We're going to continuously track your progress amongst the process, structural, and outcome measures. And all of this in the report is really going to add to your PDSAs. So when you go into your report with your QI team at your monthly QI meeting or whenever you guys have it, maybe it's weekly, you can address, okay, where's our areas of opportunities? How are we going to turn this into a PDSA? What's one thing that we can change? And that's how we're going to measure that. You can see how that one thing you changed really gets impacted in your QI reports looking at your measures. So whenever we identify an opportunity and we've tried out a PDSA, then we can go into our coaching call and we can share this one test of change that we made and how our data is reflecting the test of change that we made. We can continuously submit the data, and then you'll get another data report, and we just kind of keep doing this cycle over and over again, month by month, where we get a new data report, we're going to discuss it and disseminate it to all of our QI team, everyone working on this initiative, and continuously pick areas to improve, and even pick areas of successes and see how those have contributed to a sustained success for you all. All right. Now, I highly suggest, screenshot this if you're able to. Save this image. Of course, you'll get the slides later, but if you can screenshot it now and save it with your notes, it'll be extremely helpful because these are our due dates. So, the very first thing y'all are submitting to us is going to be your baseline data. Well, there's 2 different types, but they're both in the same time period, and they're both due by July 15th. The first is your abstracted patient level data. That's going to be an abstracted patient sample, January, February, and March. So it could be up to 45, like Shamika said earlier, up to 45, could be a lot less, but that's what's due for patient level. Now, hospital level, that is just going to be one submission, and it is quarterly, so it just covers January through March. Just one submission for hospital level. All right, and there will be no data from April to June. You're not going to be abstracting any data for April, May, or June. But starting in July, July will be where we start OHI data collection. That will be the first month of abstracted patient level data. And whenever you collect July's data, who knows when it will be due? You can type it in the chat or come off mute. But that first month of July, when will it be due by for patient level data?
August 15th.
Thank you, Shamika. August 15th. And you'll just continue that throughout the whole initiative. 1 month will be due on the following 15th of the following month for patient level data. Hospital level data is collected quarterly. So after baseline, your second one or the first one of OHI active phase will be Q3, and that will cover July through September, and that will be due October 15th. And we've got a great graph here at the bottom, just another way to see this information because it's a lot of dates at you at once. So, all right. So now I think we can go into some questions. I'm just going to leave this up while we go over the questions.
Thank you, Shelby. And I'll try to go through one of the questions that I saw first. So what's the difference between severe maternal morbidity and severe obstetric complications? They are similar because they use the same ICD-10 codes to identify women that had a severe event during the delivery admission. So if they had a stroke, they ended up in the ICU because they had congestive heart failure or kidney failure or something major happening to them, then they are going to be identified with those ICD-10 codes. Both of them use pretty much the same ICD-10 codes to identify those very, very severe events. The difference is that severe obstetric complications goes further into adjusting the measure. So if the patient came anemic or had a lot of comorbidities, then the severe obstetric complications measure takes that into account. And so it's just calculated differently, but then the women that are identified are pretty much the same. So we know that severe obstetric complications is required by CMS. So not everyone may have access to those numbers, but someone in your hospital does. And so one of the first things that you would have to figure out is who has access to those numbers, right? And we have them as optional, and it would be great if you're able to submit them to us. And those are actually easier, most likely easier for you to access than severe maternal morbidity numbers, because those you would have to create a report with your IT, techs, and figure out all the codes to identify those women having those severe events. Now, we have asked this for hospitals participating in PROMPT. So if your hospital is participating in the hypertension initiative, most likely you will have already gone through the pain of figuring out what is SMM and what is SOC, right? And who has it and who has access to it. From the hospitals that have shared with us, we know that several systems have a dashboard that already reports the number of SMM patients that you've had in the quarter. So that would be my first ask. Ask around if anybody has access to an obstetric dashboard that already has those numbers for you. And if not, start to figure out who may have access to the severe obstetric complications numbers, because again, those are required by CMS, and you can send us either one of them. Either one of them are fine. And we can send you additional literature. I'm sorry that I'm being very simple. I'm giving you a very simplified answer to your question. Truth is, it's a very complex measure, but the biggest aim is to identify women that had severe events. Do we have any other question that we need to address?
Yeah, we can probably take 2 more questions, and then we've got to start the next meeting that we have after this one.
True.
So there was I'll answer Rose's question in the chat, but there were a couple people asking for larger hospitals if those aggregate patient level data can be presented or submitted as percentages instead of numbers.
Yeah, we don't want to add burden to your work at that level. If you are a big facility, we don't ask you to do manual abstraction for all of them. We will collect that in the abstracted numbers that you will send to us for the up to 15 patients. And what we ask is that you work with your IT department, because those are the EHR integrations that you may be working during OHI to figure out the large number, right? So if you have it, wonderful, please submit to us. If you don't have them, start working with your IT department to have those numbers. In the meantime, we will add in our database a checkbox so you can tell us, we're working on it, we don't have that number yet. And whenever you have it, then you start reporting to us. Yeah, no need to do like a percentage because we do the abstract cases, so there's no need to duplicate efforts. So just, check mark if you don't have it yet, check mark that you're working on it, and then whenever you have it, start reporting. And one more question, because I know we have to end the call. Do we have anything else?
Alexa did put her email and my email in the chat. So if you have any questions, you can email us.
Absolutely. Okay, so if we missed any questions, we will send you a mass email so everybody has answers to those things. We will send you an email with tools, instructions for data collection between tomorrow and next week. Please don't delay starting that data collection process, and we're always here for you. We may do a couple of office hours for data collection if we see there's need. So if you're having trouble, let us know. We're more than happy to establish those for you. Margie, do you have any closing? No?
I'm just overly impressed by the presentation, all the people on the call, and the great questions. Thank you.
Absolutely. Thank you so much for your engagement, for your questions. It's also always wonderful to hear from you. And we look forward working with all of you. Thank you so much for coming today.